Thank you for having me here. It's my first time here. These are my COIs, my conflict of interest, and it's a challenge for me to present so many new drugs in 20 minutes, so please put your seatbelt because I want to try to do it fast. Okay? And there are many targets. There are new targets, and there are so many, and that we are doing a lot of studies in many places in the US, in Europe, many places in Asia, everywhere. The truth is we try to explain how things work and try to target or know in advance what patients should respond or not, but then we get surprises. So I'm going to talk about monoclonal antibodies and new drugs and even old drugs that have new applications. So in the anti-CD20s, there is a beauty contest, but I'm going to refer mostly to GA101. Ofatumumab in large B-cell lymphoma have only a response of 11% in patients who were priorly treated. So it's not that exciting. But GA101 have a different thing. So GA101, which is a new anti-CD20, have different features. So it seems like, they care less about having a better Fc gamma receptor 3, which is nice, have less CDC activity, but have increased direct apoptosis. So it's an interesting target. But, all the things look nice in vitro. Let's see what happened when patients were treated with aggressive lymphomas. And this is what you see here. You see that at the end of treatment, patients with large B-cell lymphoma have a response rate of near 30%. And the interesting thing is when the patients were refractory to rituximab, still have a 25% response rate when they were using higher doses of GA101. So it's an interesting drug. So what are you going to do with this? So this is what's going on, different trials. For large cell lymphoma, what matters to you is that there's a study ongoing in the world comparing GA101 plus CHOP versus rituximab plus CHOP. So this study is ongoing in the world, and to define if it's better to use GA101 or rituximab. So this is going to be a very interesting trial. Roche sell both of the drugs. Sell the rituximab and own the GA101. So I guess they're competing with themselves. This is just to give you an idea how many different antibodies. This is a partial list of what is going on in the world. But I'm going to focus on some interesting ones, And CD40. The interesting thing about CD40 antibodies in the anti-CD40 antibodies induce apoptosis and ADCC. This is the CD40 receptor expressed in B cells and in pro-survival. And there's probably some feedback between the cells. So there are two anti-CD40, the SGM40, and that is from Seattle Genetics, that's dacituzumab, and lucatumumab. The response rate with the SGM40 was very limited as a single agent in large cell lymphoma with 11 to 12%. And when they combined it with RICE, they did a study using RICE versus RICE plus SGM40. The study was stopped early. Why they stopped it early? Because the stopping rules were designed to stop the trial if the complete responses were equal in both arms. Why was that? Because the idea was that complete responses are a good predictor from outcome after a stem cell transplant. We know that. If you have a PET negative scan, you do better. If you have a PET positive or partial responses, you do worse. But this is what happened after the patients were followed. Patients who have rituximab SGM40 who went to transplant, they did much better than the rituximab patients placebo. This cannot be explained clearly, but this is what happened, and the study was terminated earlier. So probably, I don't know if the Seattle Genetics is going to follow the drug more, There's another drug, the lucatumumab, which is currently being evaluated. Now, this is CT011. is an anti-PD-1. PD-1 is a programmed death 1. I'm going to show you some slides to give you an idea of what it does. So what it does is a humanized IgG1 kappa monoclonal antibody that binds to the PD-1 and inhibits its function. So what PD-1 does is make the T cells and NK cells useless. You know, so if they don't work, they cannot kill tumors. You know, so those T cells, NK surrounding the tumor cells, they have PD-1, doesn't work. So if you start to use an anti-PD-1, in theory, you could have a better effect in infectious diseases and cancer. On the other hand, if you have an agonist for PD-1, which make the PD-1 work better, you can work against autoimmunity, allergies, or transplant rejection. So if you manipulate the PD-1, you might have different effects if you block it or you stimulate it. So what happened is there were some studies, and now this PD-1 has been shown activity in different cancers. I think lung cancer, renal cancer, etc. I think melanoma too. But in lymphoma, there's a study that is ongoing at MD Anderson using a combination of rituximab with CT011. This study is being submitted by Dr. Satva Nilapu, where he's going to show not only high response rate in patients who were responsive to rituximab before, but also a very high number of complete responses in this trial. What I'm going to show here is a phase 2 trial that was reported by the company, and this needs to be noticed because it hasn't been a peer review information. And what it shows is patients who receive an autologous stem cell transplant for large B-cell lymphoma, recurrent, they were put on maintenance with CT011, again, PD-1 inhibitor. And what happened is, you see, the progression-free survival was 70%, and when they compare with CORAL patients with similar features, was 47%. The overall survival was better in the group receiving the PD-1. So this is an interesting drug. Probably it's going to be studied more. The company is focusing a lot in solid tumors, so I don't know how much involvement they want to have in other lymphoma at this point, but certainly it's a very interesting mechanism of action. I'm going to jump to conjugates, and this is a drug that we were working for at least 5-6 years. And this is an anti-CD22 bounded to calicheamicin. Probably many of you are familiar with ebratuximab, which was a naked anti-CD22, and mTOR, they have calicheamicin. So this is an IgG4 anti-CD22 bound to calicheamicin. And the first trial, the phase 1 trial, was for patients who have B-cell lymphomas expressing CD22, and the patients could have any number of prior treatments. The median number of treatments were 4. And what you find out is that the follicular lymphomas have 68% response rate, quite interesting, and the diffuse large B-cell lymphoma was almost all of them refractory patients. You know, many of them have up to 10 treatments and failing many different prior regimens, and they only have modest activity. So then they jump to a different trial combining rituximab with CMC544. This was a different design. The patients had to have only up to 2 prior treatments, and they have to have certain degree of sensitivity to the last treatment in group 1 and group 2. Group 3 was basically the same situation. Patients who were refractory to many prior treatments, no matter how many treatments they have. But in this one, the definition of sensitivity was that the patient have a response lasting for 6 months from the beginning of the treatment, which is different of most of the definitions for rituximab refractory, because rituximab sensitivity is defined as the last treatment of rituximab containing regimens for 6 months. So in any case, this is what it was seen on this combination of rituximab plus CMC544 in follicular lymphomas, more than 80% response rate, which was okay, was nice. But what was surprising was the response rate of near 80% of the patients who have large B-cell lymphoma, you know. And now the drug has shown also activity in acute lymphoblastic leukemia. And this is the survival of the patients for progression-free. You can see, you know, the number of months, 30 months, and the diffuse large cell lymphoma, you have patients still up to 2 years still not progressing. I have some of those patients, you know, with refractory disease, large B-cell lymphomas who have involvement of the ribs, who couldn't make it to transplant because they don't have blood counts or they didn't collect, and they were treated with this drug, and they're in a long-term remission. So it's a quite interesting drug. The main toxicity is thrombocytopenia, and there were 2 cases or 3 that have severe liver toxicity on all the trials together. There is a study ongoing where patients who didn't qualify to transplant because refractoriness or any other reason, or they were failing more than 2 or 3 treatments, they have bad prognosis patients. You know, they were going to transplant, but most of the patients have at least 2 prior treatments. And the response rate was 21%, and there was collection in 5 of 7 patients. This is a preliminary data. This is a bispecific antibody they call it BITE, but in reality it's called blinatumomab. And this is the response rate on large cell lymphoma. You can see a very interesting response rate in this group too. You know, this is another drug. The main toxicity, I think, of concern was some patients developed some encephalopathy in a different dose. This is another one that we're actively working, and soon there will be a combination with rice with this drug. It's SAR-3419. It's an anti-CD19 bounded to a toxin. This is what you see in diffuse large B-cell lymphoma. This is a waterfall graphic that shows how many patients have a reduction in the tumor. And many of these patients have many different prior treatments. It's not like they have 1 or 2. There were patients who have failed all the treatments. And you can see many patients have a reduction on the tumor size. So this is something that you're going to be watching soon, the SAR-3419. You know, it's a very interesting regimen. Lenalidomide. It sounds a little boring because you hear a lot, but in reality it's a very interesting drug that have a lot of activity. You know, data from Roswell Park suggests that the drug have more activity in patients with non-germinal center. You know, I don't know if we quite can accept that. There's a larger study ongoing in the world proving that. But the way the lenalidomide works, I don't know how it works. You know, it works in the tumor cells, in the adhesion molecules like ICAM. You know, it also works in the interleukin-6, TNF-alpha. Also increase the interleukin-2 interferon gamma, increasing the activity of natural killer cells, maybe anti-angiogenesis. There are many mechanisms of action that can be involved on this. But I think people who have tried lenalidomide on studies or off studies, they get surprises. You know, in patients that you were ready to send to hospice, and they are alive in remission. You know, I have a patient who have a non-germinal center lymphoma who failed 2 transplants, an auto and an allogeneic. He failed radiation in the same site that he had radiation twice with proton therapy that they tried to do in my institution. He grew back there. We put him lenalidomide. He's 2 years out. He doesn't want to stop. He's afraid that if he stops, the disease will come back. He was refractory to hypercVAD, refractory to rice. So we were ready to give him up, you know. So it's a very interesting drug in certain cases that you won't even expect. I think most of the studies show response rate in the range of 30%. Even though they claim that their responses are better in patients with non-germinal center, activated B lymphocytes, you can see transformed lymphomas, mostly follicular, they have responses too. And we all in our institution have responses in patients that we treat on study or off study. You know, RAD1, you know, it's an mTOR inhibitor. You know what it is. I'm not going to slow down too much. But, you know, in diffuse large B-cell lymphoma, have a response rate of 30%, 28 plus 2%, and also very interesting responses in T-cell lymphomas and in Hodgkin's lymphomas, you know, follicular lymphomas too. So we all have patients who were treated with RAD1 off study because we're desperate, or on studies, especially with Hodgkin's, our own institution. Currently, there's an ongoing effort using RAD1 in the world, combined as a maintenance for patients who have intermediate risk or high risk by IPI, who achieve a complete remission either after R-CHOP or R-EPOCH. So those patients who achieve a complete remission who have a high-risk features, they will go on placebo or 1 year of RAD1. And the study is ongoing at this point. Many other studies combining RAD1 with other different drugs, histone acetylation inhibitors, etc., are ongoing in the country. BTK inhibition, this is Dr. Bruton, and I'm going to basically, the B-cell receptor signaling is a target for killing B-cell lymphocytes. You can target them by blocking the SYK with a drug called fostamatinib. You can target a PI3K inhibition or a BTK inhibition. Or probably you can combine all of them, That's even more interesting to do, But also you can block downstream like AKT inhibition. So there are many targets with the BTK. And for those who have done studies with BTK inhibition, the main toxicity is going to see the doctor. There's not too much toxicity involved with the BTK inhibition. With the PI3K inhibition, you can have some rash. And patients with SYK have thrombocytopenia. So there are different toxicity depending on what part of the B-cell receptor signaling you want to block. And in this, you can see the targets. This is a slide I got. SYK inhibition, this is fostamatinib. And what it did, the response rate that you see here are less than 20%, but in large cell lymphoma, heavily treated patients, in the most recent update that has not been published, I think, the response was 21%, with 1 patient of 5 of the responders having a CR. So there are more studies right now ongoing using fostamatinib with looking after the SYK inhibition. This is the older PCI 32765 BTK inhibitor. Fascinating activity in mantle cell lymphomas and small lymphocytic lymphoma CLL. I mean, surprisingly excellent responses, And what it does is, is blocking, because you can see the BTK is blocked by using FISH technology, This is what they found. If you use more than 2.5 milligrams per kilogram per day, you can certainly block all the BTK, And this is the different activities. Look at this activity in CLL, 69%. The activity in mantle cell lymphoma, 78%. In diffuse large B-cell lymphoma is modest, 29%. Also, the patients were heavily treated, And there's studies are going right now combining Rituxan CHOP with BTK inhibition in a broad group of large cell lymphomas, a phase 1, and then probably they will try to recognize some signaling and go further. Probably the best target for this one will be, of course, an activated B lymphocyte, not the germinal center group. The adverse events, very limited, most of them grade 1 and 2. This is the last I'm going to talk. This is a work from there was a private group in California that treated patients with Bendamustine with large B-cell lymphoma. And, there were responses of 52%. Small group, private practice, nobody cared too much, But then came the group from Japan, Dr. Ogura, who reported in patients who were no candidate for transplant. They treated them with Bendamustine, and you can see the responses, and you can see that half of the patients are progressing within 6 months, which, you can say, well, this is not a surprise. You can get this with any treatment. The interesting thing is the low toxicity, and what is more interesting to me is the tail. Dr. Champlin, who is a transplanter, it probably in a group of these patients, you can now get much better than this. You know, this is at 20 months, having 40% of the patients still without having progression. It's a very interesting option for patients who are usually older or unfit. You know. So in conclusions, there are too many drugs and not too much patients, and we're trying to do many studies with limited resources. At our institution, you know, despite our be motivated to put patients on trials, probably we can put only 15% or 20% at best of the patients on trials. In the community, I think it goes as low as 3% or 5%. Dr. Juni is very interested in trying to get targets. You know, we have a lot of research trying to recognize which patients respond, doing more extra biopsies in patients who are on trials to see if we can see signaling and that can be predicting what patients will respond or not. The other thing is we think is interesting is trying to move drugs that have activity the fastest possible to second line and front line to see what patients can benefit with this. You know, we try to put most of the patients who are failing to an auto transplant or who are not candidates to transplant when it's good for them, trying to put them on these trials, because as probably it's a group of patients that standard chemo doesn't work for a long time either. I didn't mention some preliminary data that is now using STAT5 inhibitors that are also very interesting in large cell lymphoma. That's it. I don't know if you have any questions.